Hi guys, welcome. We are going to be talking about Osteogenesis Imperfecta. So we're going to start talking about case 1 of a 2-year-old male referred from local hospital with shortened, painful left lower limb after a breech delivery. His mother had a previous history of an early neonatal death in a first pregnancy, and on examination, the patient had low-set ears with a blue sclera, a flat nasal bridge, short limbs, elbows were not distinguishable from the wrist, and there were multiple protrusions and dimps on the chest. There was a normal back, and there was a club foot on the right side. Okay, so we did a skeletal survey in which showed multiple diaphyseal fractures at different stages of healing. We did a chem test which showed calcium of 2.18, phosphate of 1.65, magnesium of 2.7, and alkaline phosphatase of 370. Then UND, urea, creatinine, and electrolytes. We saw the sodium was 130, potassium was 4.5, urea was 4.6, and creatinine was 32.1. Then full blood count had a white cell count of 13.1, hemoglobin of 12.7, and mean corpuscular volume of 87, and a platelet of 256. So there was a bit of a hypokalemia. We actually calculated the corrected calcium. We saw that there was a hypocalcemia, so the calcium was low. So we did test urine calcium, which was 1.07, and urine creatinine was 1.36. Then we did the urine calcium to creatinine ratio, which was raised at 0.57. So our diagnosis was osteogenesis imperfecta for this patient. Okay, we're just going to talk about this diagnosis of osteogenesis imperfecta. So it's also called brittle bone disease, and it's an inherited connective tissue disorder. It can be autosomal dominant or recessive, so there are different types. And osteogenesis imperfecta is caused by mutations in genes that encode either one, they can be type 1 collagen, which is alpha 1 and alpha 2 chains, okay, or it could be in the proteins involved in the post-translational modification of type 1 collagen. So it could be the type 1 collagen itself or the proteins involved with the post-translational modification of type 1 collagen. So type 1 collagen is a structural protein for bone, ligaments, skin, and sclera. Then the types of osteogenesis imperfecta, there's type 1 to 16, then type 1 to 4 are more common. Type 2 is lethal, which die in utero. Type 1 is mild, type 4 is moderate, and type 3 is severe. Okay, so type 1, they can actually live normal life and have a normal life expectancy, but type 3 usually, I think when they get to adolescence, they are usually wheelchair bound. They have kyphoscoliosis and other problems that around that age, and so they can succumb to cardiopulmonary disease. Then the clinical features of osteogenesis imperfecta, so there are basically 4 cardinal things that we look at. So we can use the BITE as a mnemonic, and B standing for bone fractures. So these patients tend to have bone fractures. They actually are called glass children that have bones of glass, and they can just fracture. Some can actually have fractures from utero. In utero, they can have fractures at birth, fractures from just minor collisions. Then, like I said, the eye is for the iris. There will be a blue sclera, so that white part of the eye will be blue. And like we said, type 1 collagen is part of the protein that forms the sclera, so it's expected that the iris will be blue, because what happens if the sclera is thin, or if the sclera is a bit of translucent or opalescent, you can actually see the uvea that's underlying, and the uvea is blue. So in this case, the sclera is affected, and you see it as a blue sclera because of the underlying uvea. Then the teeth, there is opalescent teeth with a bit of dentinogenesis imperfecta. Okay, so the teeth are sort of, if you shine light through them, you can almost see the light through the teeth. It's typical of these patients. And then they have ear problems. So for the ear problems, they can have conductive deafness in infancy, but later on in life they can have sensory neural deafness in the second and third decades of life. Okay, so the investigations that we do a skeletal survey, and then we can do lab findings, which check the alkaline phosphatase. We want to check for the urine, to check urine calcium. Then we can check the C-terminal propeptide of type 1 procollagen, and this is usually low, and the C-tailor peptide of type 1 collagen, this is usually high, and the propeptide is a marker of bone formation, so it's low because there is. So investigations, you can do histology as well, which will show disorganized woven bone in severe cases, and genetic studies can be done. Genetic analysis of the cDNA skin, do a fibroblast culture. Then we can do genomic DNA testing for the collagen 1 alpha 1 and alpha 2 in white blood cells. Usually this is done when the clinical diagnosis is not clear, but osteogenesis imperfecta can be diagnosed clinically. Then management is the goal of the therapy is to reduce fractures, to prevent dysmorphism, to minimize pain, and to maximize mobility. So you can use biphosphonates. These are analogs of pyrophosphates, so they are potential inhibitors of bone resorption. Like I said, they will be increased bone resorption. So we can use IV palmidronate or IV zoledronic acid. The oral ones, they can be used like oral risdronate, but the problem is they can cause upper GI bleeding, and we usually give calcium and vitamin D supplementation prior to the treatment. Then the multidisciplinary approach that we use, we need the surgical management for fracture prevention and early stabilization of fracture, as well as early mobilization of the fractures to facilitate quick recovery. Then we have physical and occupational therapy. This keeps the patients mobile, and psychosocial support. This is to deal with issues of stigma, the parents' guilt. So most of the time you find that these patients with multiple fractures at different stages of healing, it can be mistaken for non-accidental injury, and if this is the case, then the parents can be accused. They can even be put in difficult situations because people think that the parents actually causing these injuries, but in fact it is this osteogenesis imperfecta. So this is a big issue of distinguishing the osteogenesis imperfecta from non-accidental injury. Then we also have issues of avoidance of contact sports. Then at follow-up, we want to do spirometry every 2 years. We want to check their growth. Then we want to also do formal audiometry at 9 months. Then every 2 years, remember, they can be either conductive or sensory neural deafness, so we need to check those. Then visual assessment every 2 to 3 years, and a dental follow-up. Okay, then because of the Osteogenesis imperfecta, then we do rehabilitation in the less than 3 years. For about 3 years, we do occupational and physiotherapy. Okay, then we do a bone mineral density every 1 to 2 years. This is a dual energy absorptiometry or a skeletal radiograph to check if the bones are strong enough. Then the prognosis is determined by the type. So we said there's types 1 to 16. The lethal type, the type 2, they will die in utero or in early infants. Then the moderate or severe will suffer premature deaths from complications including severe pulmonary infections. If they have, let's say, calcific, they could have also copulmonary or any other cardiopulmonary compromise due to thoracic deformities. And they have the mild, they can actually have a normal